This afternoon's program will be on the clinical efficacy and safety of SGLC2 inhibitors and their place in the management of type 2 diabetes. This activity is supported by an educational grants from Janssen and Merck. We thank you for your continued support. Our first presenter will be Dr. Morris Brown, and Dr. Brown is currently chair of the Family Medicine section. Angie, you want to get him for me? Yeah. Dr. Brown is currently chair of the Family Medicine section here at the NMA, and a graduate of Meharry School of Medicine, practicing in the Dayton, Ohio area. I welcome to the stage our first presenter of today.
Talking again about the role of the kidney in glucose homeostasis. And I have no disclosure other than the ones I've already mentioned. And we've already talked about the omnis text. See how fast this is going to go? I don't think I need to review that with anybody. I don't want to draw your attention to the kidney, because now we'll be talking about that organ and that organ alone. So here we are. This is how it looks, and this is what happens in the kidney. How does the kidney contribute to homeostasis? It's by actually three processes, two of which you see here. It's by glucose filtration, meaning the glucose enters the kidney, and then the glucose is reabsorbed in the kidney. As a healthy individual, that normalizes glucose. Why do we need the kidney to reabsorb glucose? Because in between meals, we still need energy, so that keeps us from having to graze all day long. We reabsorb glucose when it enters the kidney. That's a positive that works. It's done by two basically receptors, the sodium glucose co-transporter, and also GLUT, which is facilitate glucose transport from the cell. There's SGLT2 in the proximal convoluted tubules. There's SGLT1 in the distal tubules, and there's a reason why that difference is there. We'll talk about that going forward. And also, the GLUT, as you see, reabsorbs, and you might can see it better on the next slide, reabsorbs the glucose on the opposite side of the cell, on the other membrane, thus, and this is the next slide here. Again, a very descriptive cartoon of what happens. So there's a gradient that allows, once the sodium goes through the sodium glucose transporter, the sodium transport in, there's a gradient created, hypertonic gradient, so therefore glucose then follows sodium. So that's on one side of the membrane, but then on the opposite side of the membrane, facilitated by GLUT2. And this is what happens in the proximal tubule. So there lies an opportunity. If we're saying that within our diabetic population, the kidney plays a role, so this is what happens, and it's all controlled by a threshold. Now that threshold in a non-diabetic is about 180, which is about 162 grams of glucose per day. So until that is exceeded, that kidney reabsorbs all of the glucose. What happens in our type 2 diabetics? Well, the renal glucose reabsorption is increased in patients with type 2 diabetes because the threshold has been increased. So that threshold goes from 180 to 240. So what are we saying? There's no excretion. In the type 2 diabetic, all of that glucose is reabsorbed, which in a non-diabetic is good because, again, there's no excess. With a healthy non-diabetic, you're going to excrete that glucose once it exceeds 180. In the type 2 diabetic, he still absorbs, continues to reabsorbs. The type 2 diabetic will not excrete until the threshold is exceeded, and that threshold in the type 2 diabetic usually starts around 250, and it can actually, or 240, it can actually exceed that depending on the length of the diabetes. So here's an opportunity for treatment. If we can then encourage that kidney to secrete glucose earlier, we're going to prevent hyperglycemia, and that's the unique way these drugs work. They have nothing to do with insulin, which is unique, so therefore we don't have the complications that you'll see, and the other gentleman will explain what those are. I said I'd make it quick.
Our second presenter of the day for this session is Dr. Corbina Dubafour. Dr. Adubafor is a longtime presenter and friend of the family medicine section. He had his initial medical school training in Ghana, at the University of Ghana, and did a residency in internal medicine at Kaiser Permanente in Oakland, California. He's really a tremendously involved individual in the treatment of diabetes in his community. Please help me welcome Dr. Kwabena Adubafor.
Thank you so much. And the reason why I'm applauding all of you is the fact that you're still here with us. And what are you doing? You spent 5 seconds doing this. I have like 200 minutes of talk. I'll try and be quick. So I need all you guys to also listen very quickly, if that's possible at all. But here's my title, right? So my charge this afternoon is to provide the clinical evidence to support the use of SGLT2 inhibitors as monotherapy and in combination in type 2 diabetes, with an overview of their use in patients with high blood pressure, as well as patients with renal failure. So let me see if I can do this in 20 seconds. So here's my disclosure. And then we're going back to the first lecture, because we're still harping on this so that when you leave here, it's still subliminally in your mind. We're going to go on individualized treatment when it comes to type 2 diabetes. We're going to find out the type of type 2 diabetes the patient has, and we're going to use this whole gamut of agents in an appropriate manner. But as Mo said, we're concentrating today, or this afternoon, just on the SGLT2 inhibitors. And there's so many other drugs coming. I mean, this is even going to become more complicated than ever before. Look at the list here of agents we've never heard about, but targets that we've never heard about being primed and prepared to come out as pharmacotherapeutic agents in the near future. So things are going to become a little bit more complex. But I think that in the light of this, there's also hope for us to really begin to understand at the molecular level what's really going on with our diabetic patients, so we can intervene in a more appropriate manner. So remember, there was a time when diabetes was diagnosed and controlled based on the extent of glycosuria. That was when Jim was born. I was not born then. And then yesterday, he showed this really astute clinician who, for some strange reason, has been lost when it comes to Greek and the Greek physicians that we normally discuss. You know, everybody talks about Hippocrates and the others, but this guy described like diabetes in such an astute manner, and you know, talking about how there's a constant flow of urine and it's as if you're opening up aqueducts. It's just classic way to describe diabetes then. I'm not going to dwell on this because I think Mo did a fantastic job of explaining that the two SGLT2 receptors that are at play here, one of them, which is in the proximal portion, absorbs 90% of all the glucose that is filtered by the kidney. The other one, which is a little bit more specific but not as robust in terms of absorption, is the SGLT1, which absorbs only 10% of the remainder of the glucose that's filtered through the kidney. So again, the concept of this is what happens if you block this? And it turns out that there is a disease in nature where these individuals lack SGLT2, so they're always, I'm not going to use the word pee obviously, but they're always urinating in abundance, but it has no clinical effect whatsoever on them. It turns out that the kidney just does more than just shed glucose. It's also involved in gluconeogenesis, and Mo mentioned it. It's a way in which God has designed so that we can stop eating and we can still continue to have our brains work, our heart continue to beat. The same role that you have for the liver when it comes to gluconeogenesis, and how a significant role it plays, especially when you're asleep at night. And how, again, depending on the patient you're looking after, the extent of gluconeogenesis, the extent of fasting blood sugar is totally different. And why you cannot have the patient on 10 units of Lantus or Levemir for 1,000 years, and every time the person checks their blood sugars in the morning, it's 2,000, and you've not done anything about it. Change the dosage, equip the patient to be able to do that by themselves. But coming back to the kidney, so there is an increased SGLT2 expression when it comes to type 2 diabetes. And hence the reason why this defect exists to begin with in people with type 2 diabetes. And so basically the inhibitor is to try to overcome this problem that you have. And this is all the effects that we currently know happens when you give someone an SGLT2 inhibitor. There is insulin sensitivity in the muscle. There's GLUT4 translocation, so the ability to grab glucose away from the bloodstream into the appropriate quarters is enhanced. It increases insulin sensitivity in the liver. There's decreased glucose 6-phosphatase, decreased Cori cycle. You get lactic acid being converted into glucose as well. And these inhibitors have the ability to stop that from happening in the Cori cycle. PP carboxykinase also increases the glucose load as part of gluconeogenesis. This is also decreased in terms of its activity. But at the end of it all, what you want to see is an improved in beta cell function, which these agents allow. Now, on the top there, you see a reversal of glucose toxicity. And I really want to impress upon all of you the fact that, yes, we talk about the chronic complications associated with hyperglycemia, but there are also acute complications associated with hyperglycemia, completely different from diabetic ketoacidosis. And I've said this before, all you need is a blood sugar of 200 or more for 2 hours, and all your wound healing ability, your ability to fight infections, all that becomes impaired. All you need is a blood sugar of 200 or more for 2 hours, and the ability for your nerves to communicate with each other becomes impaired. So doing everything to decrease glucose toxicity in our management of type 2 diabetes in the clinic, absolutely crucial. You cannot allow the patients to continue to walk around a little bit sweet, as some people used to say. So it's absolutely crucial that we get rid of this kind of thinking. And this is just absolutely wonderful work. And this is one study in which Ramon, is that the way to pronounce that researcher's name? Ramon and his associates actually collected urine samples, and you can get proximal epithelial cells from that. And they cultured these, and it shows clearly, in terms of protein expression, upregulation of SGLT2 receptors, and in terms of glucose uptake, those patients who had diabetes in red had an increase in terms of expressing SGLT2 as well as the cells taking up glucose. So there is proof of concept when it comes to how this receptor plays a key role in type 2 diabetes. So here are the list of the agents which have been approved by the FDA. Invokana was the first one to come out. So those of us in primary care obviously gravitated to that as an initial agent. But there's also dapagliflozin, there's Zigdur, which is DAPA and metformin combined. There's Jardiance, empagliflozin, and there's Glixambi, which is a combination of EMPA and linagliptin. So in terms of combination treatment, these agents are also available to be used as such. And in terms of monotherapy, you also have these agents as well. So who's the ideal patient for these agents? Again, those who cannot tolerate metformin, patients unable to sustain glucose-lowering effect, those that are goal on insulin therapy, in individuals where you like to see some weight loss, it's important. There should be a little bit of caution when you're using it in the elderly, and for reasons I'll go into in due course. So if you're using them in monotherapy, how much A1C reduction do you expect to see? And I think that should be one of the questions I should have put up. In individualizing treatment, when you sit down to discuss the goal of treatment with a patient, at least you should come up with an idea of why you're adding that second or third agent and what you expect to see in terms of the benefit 3 months down the line in terms of your A1C level. So when you're not there and you're intensifying treatment, you and the patient can come to an agreement as to why this is taking place. So how much A1C can you expect? What I've done here is to combine all the various studies that's out there in terms of what you get with CANA, This is after 26 weeks of the 300 milligram dose, and the A1C reduction is about 1.14 compared to placebo. And these patients all started with an A1C roughly about 8. This is the dapagliflozin study as well, in which you get about 0.66%. Empagliflozin gives you about 0.5%. Empagliflozin, I think that's European. It's not in the US market, is it? Right. And that gives you about 0.8%. So anywhere from about 0.5 to 1% reduction in A1C, you can see utilizing these agents in monotherapy. And then what happens with those individuals with a longer duration of diabetes? Because remember what we always were taught, that type 2 diabetes is a progressive disease. And that the patient who is failing treatment is not failing treatment because that person is non-compliant. It's failing treatment because that is the natural history of the disease. So you may need to look elsewhere, especially if the beta cells have failed and are no longer producing any insulin. Why not utilize an agent which is completely insulin independent in terms of its actions? So those longer duration of diabetes patients, does this agent still work? And this is a study that was presented at the EASD back a year ago, where they stratified the baseline A1Cs as well as known duration of diabetes, and they did 4 things. Had patients on monotherapy, add-on to metformin, add-on to metformin plus an SU, and then add-on to metformin plus pioglitazone. And here the baseline A1Cs, those who had an A1C of less than 8, early onset diabetes, let's call it that. Those with an A1C between 8 and 9, those with an A1C of more than 9. The duration of diabetes grouped into 3, less than 5 years, 5 to 10 years, and then those with type 2 diabetes of more than 10 years duration. And you look across the board, and for both A1Cs of 8 to 9 and more than 9, again, as always in all these studies, the higher your A1C, the more robust a response traditionally people get. And this is clearly shown here, in which your A1C drop is about 1.48 compared to 1.25. And this is also, seems to be a little bit dose related. The higher dose of Cana ended up with a much robust finding in terms of A1C reduction. And it didn't matter in terms of the duration of diabetes, right? The agent worked across the board. So the conclusion from the study authors were that Cana improved glycemic control across a range of baseline A1Cs and disease durations. You saw a greater A1C reductions were seen in patients with higher baseline A1Cs. And that data supports Cana as an option for patients with type 2 diabetes across a range of both baseline A1Cs and type 2 diabetes duration. How about in the elderly? And this is another study looking at patients between the age of 55 to 80. They included 55-year-olds as elderly. Okay, I'm going to change that. Let's make it 70 to 80-year-olds. Well, the baseline characteristics were similar across the groups. Mean age of 63.6, hemoglobin A1C of 7.7, BMI, classic BMI that you see in our regular primary care clinics. And these were all inadequately controlled on stable anti-hyperglycemic agents, right? And again, 2 doses, 100 milligrams of Cana compared to 300 milligrams compared to placebo. And you see all the changes that you get here in terms of A1C reduction. There's an improvement in HDL and then systolic blood pressure as well as weight change. We'll talk a little bit more about that in due course. And the conclusion here, again, in the elderly individuals in your practice, this is a viable option if you're going to move on. How about in combination therapy? Do you get a more robust A1C reduction by doing that, yea or nay? And this is, again, a summary slide of all the various studies out there looking at these agents added on to metformin. And not too much different from what you get with the monotherapy studies as well, anywhere from about 0.5 to 1 percentage drop in A1Cs. And this is a study looking at sasagliptin, right, compared to, added to dapagliflozin, the SGLT2 inhibitor, and comparing that to either Saxa alone or DAPA alone among type 2 diabetes patients who failed metformin. A1C was between 8 to 12%. They had about 500 patients in this study. And again, at the end of 3 months, looked at the data. Right, and it looks like the combination gave you at least a nearly 1.5 percentage reduction in A1C compared to either agent alone. So there is some sort of additive effect when you combine the two agents. Hypoglycemia, a little bit more compared to either one alone as well. So by and large, these agents in monotherapy as well as in combination therapy give you a satisfactory A1C that all the other agents out there will give you, with less of a risk of hypoglycemia, less of a risk of weight gain, as well as an impact on blood pressures as well. And this is the SGLT2 inhibitor data on hypertension and its clinical impact. And again, just like what I did with our first lecture, painting the background that what you want to avoid is coronary artery disease in your patients, because that's the number one cause of why patients with type 2 diabetes die. Same thing here. Let us not forget why the patient is sitting in front of you. The ADA clearly spells out what kind of blood pressures these patients ought to have. So again, if you have an agent that will give you an additional help in terms of bringing down your systolic blood pressure, because you want to avoid this whole train of where increasing systolic blood pressures worsens coronary outcomes or cardiovascular disease mortality, use those agents that are out there that can help you do this. And where do we have the evidence for this? And, just another point I wanted to make. There's a BP difference of just 10 millimeters of mercury associated with a 40% effect on CV risk reduction. So again, just like the weight issue in type 2 diabetes, where, I got into trouble for not recognizing the patient for losing a 4-pound weight loss, you don't need too much in order to ensure satisfactory benefit in terms of the outcomes that you're looking to avoid in these patients. So 30% reduction in the risk of ischemic heart disease, 40% reduction in risk of stroke with just a 10 millimeter drop in systolic blood pressure. So again, in monotherapy, how much of a millimeter of mercury drop can you see with these agents when it comes to blood pressure? And again, it's anywhere from 2 to about 8 or so millimeters of mercury drop. So again, an additional benefit of these agents when they're utilized. Same thing when added to metformin, you'll see anywhere from about 4 to 6 milliliters of mercury drop. So every little thing that we can do in order to help with outcomes, if that agent is offering you that opportunity, there's no reason why we can't pounce on it and utilize it to the benefit of our patients. And you're getting a reduction in both systolic and diastolic blood pressure, either in combination therapy or with monotherapy with Saxa. This one is empagliflozin and linagliptin combination. How about patients with renal impairment? So true or false? Can you use an SGLT2 inhibitor in a patient on hemodialysis? The answer is? I can't hear. Are you tired or something? I want to hear this one more time. The answer is? Exactly. I'm so happy you're all awake. And we really appreciate all of you for sticking with us, because it's been a long day. You cannot use it, obviously, in patients with hemodialysis if they're no longer making any urine. Because don't forget, the whole concept is that you're asking them to improve or increase the extent of glycosuria so that you can get rid or micturate the urine away. Thank you. I'm learning from Jim, right? So you can micturate everything away. But the question then arises, so at what stage of renal impairment are you comfortable utilizing these agents? Can you go as far as stage 4 CKD as long as the patient is utilized, as long as the patient is making urine? And why is this important for us to consider? It is important because approximately 1/3 of the patients you've seen in the clinic when you get back next week have some degree of renal impairment. And the ability to lower glucose is directly proportional to GFR. So using dialysis patients is contraindicated when it comes to the SGLT2 inhibitors, right? You should also be aware when you're utilizing these agents that intravascular volume depletion can occur as you're getting rid of your glucose load. Especially in the elderly person who comes and says, I'm feeling dizzy, you always should make sure that that's not because of the fact that they're hypertensive. You may get a slight bump in creatinine as a result of the intravascular volume depletion. So these are things that you need to be watchful for. And this is, again, man, this is terrible. You can't see this too well, but this is an abstract presented in diabetes care looking at various stages of renal impairment and seeing whether these agents across board did well in those patients or not. And the GFR, the most severe reduction in GFR was less than 15 to 30. And across board, they had an impact in terms of A1C on these individuals. So complete CKD stage 5 or hemodialysis, you're no longer utilizing it. But if the person is still making urine, there's no reason why you can't give it a shot to see if it works, taking into account the fact that you'll be more mindful of volume depletion in these agents. Right, and there's another study trying to address the same issue. How useful are these agents in patients with various stages of chronic kidney disease? And then this is a very interesting study too, looking at microalbuminuria effect of these agents. And this is one that involved NMA. And this was about 458 type 2 diabetes patients, pooled data with pre-existing microalbuminuria. Anything from 30 to 300 is your definition. And so what is the effect of giving them 10 milligrams versus 25 milligrams or placebo on the urinary excretion of a microalbumin? And this is added on to standard therapy. And lo and behold, there was a reduction in the extent of microalbuminuria. So something is happening within the renal vessels, within the kidneys, that's changing the way these agents, this albumin are being filtered, that would result in a reduction. So maybe, just maybe, in addition to having an impact on microalbuminuria, these agents, and again, this is just one study looking at one of them, doesn't mean that it's a group effect. But the long and short of it is that these agents may actually confer some degree of renal protection if this turns out to be true in much larger studies, and that they may have an effect in lowering blood sugar as well as decreasing intrarenal blood pressure and hence any kidney damage as a result of that. Okay, so the take home then is that, and Mo mentioned this as well, the action is completely independent of insulin secretion. They reduce hyperglycemia without hypoglycemia. You can utilize them in both monotherapy and in combination. They have a beneficial effect on blood pressure. They can also cause weight loss, may have a role in early pharmacotherapy of type 2 diabetes, avoid when it comes to CKD patients. So I think, I think I'll end here instead of going on, because we know this is the effect they have on weight. And the weight loss is anywhere from about, 5 to about 10 pounds in terms of the weight loss associated with this monotherapy, both and in combination therapy as add-on to metformin. So thank you so much for your attention.
Thank you very much, Dr. Dubofor. For those of you who may be viewing this online, the reason why several of our presenters are alluding to in previous presentations, we've had a very extensive diabetes educational program this afternoon. So when you do review this online, please appreciate you're getting the full benefit of that education along with the opportunity this afternoon. Our final presenter of the afternoon is someone who really needs no introduction whenever talking about diabetes. He is Dr. James Gavin, MD, PhD. He was recently identified as a living legend in diabetes management and therapy. He's a long-standing friend of family medicine and a colleague and a gentleman I want to emulate as much as I can. Please welcome, what's your name? Dr. James Gavin.
Well, I'm glad to see that Dr. Jones still has his usual quotient of levity for this late in the afternoon. So my charge is really to talk with you about some of the more salient properties of these SGLT2 inhibitors. And fortunately, my colleagues who've preceded me will have already covered some of the more important points. So I'm going to rush through some of the duplications. These are my disclosures. And I think it's important to keep in perspective that when we look at why we are concerned about the sting of diabetes, hyperglycemia remains an important feature of that, because none of our organ systems, when exposed to chronic hyperglycemia, gets a pass. All are subject to deleterious effects. And so the complications that we worry about are all going to be mediated in part by sustained hyperglycemia. And so to talk about agents like these SGLT2 inhibitors, which essentially bypass any dependence on beta cell function and go straight to reducing the exposed burden of glucose by using glucosuria as a therapeutic intervention, becomes a new and exciting thing for us in diabetes therapy. Because there are a number of needs that we've had in diabetes that, quite frankly, have remained either unmet or have been inadequately met. Things like treatments that can modify the course of the disease, treatments that are effective independent of the status of the beta cell, and thus indifferent to the stage of the disease at the time you're encountering the patient. We certainly have heard enough about avoiding weight gains and hypos. We want to make sure that we can actually promote, in fact, weight loss. And then we need treatments that are either neutral or hopefully beneficial in their impact on other cardiovascular risk factors. And we need treatments that people are going to stay on. Easy to use and reliable in their sustainability. And so when we look at the nature of agents that are available to us in diabetes, the first thing to notice is that we got a lot of things to accomplish. We're trying to lower glucose, yes, but we're trying to do it without gaining weight, without inciting hunger. We want to reduce the workload of beta cells, and therefore we reduce gastric emptying rates and glucose absorption rates, shut down fasting hyperglycemia by turning off the liver's ability for gluconeogenesis, and then, of course, increase insulin, both secretion and action. None of these drugs is capable of doing all that stuff by itself. And so the complexity of diabetes means that we're going to depend on complementary actions by a number of these agents, many of which only do one or two things. But some of them, the more novel recent agents, we've just talked about the GLP-1 receptor agonists. One of the reasons we're excited about them is because they can do a lot of stuff. But now we've added to this mix the SGLT2 inhibitors, and now we're starting to see even more capacity for complementary action. Importantly, when we talk about agents that are independent of changes in beta cell function, it means that we are now talking about agents that are capable of acting on hyperglycemia anywhere it appears in the natural history of this disease, as long as the kidneys are adequately functioning. That's a new approach and an important one. And it gets us to some of the critical challenges. We've lived with therapies that have given us inadequate postprandial control. We've talked about the weight gain and the hypos, contraindications, and therapies that have not had any effect on the progressive loss of beta cell function. And this is the hope that we've been living with. We want to address both fasting and postprandial hyperglycemia in a sustained way over time. We want to do it safely, without the risk of all of this baggage, and we certainly ultimately want to reduce vascular benefits. And so you've heard about the benefits of glycosuria. I don't think I need to talk about these. Both Mo and Kwabena have talked eloquently about what the kidney is doing and how. But what I would say to you is that there's a robust development program going on. We know now in the US, DAPA has been approved, CANA has been approved, IMPA has been approved. We've talked a little bit about IPRA, but it doesn't stop there. ER2 gliflozin is under development. Gliflozin is under development. And there's even a development program for agents that are combination SGLT2 and combination and SGLT1 inhibitors. So both sets of transporters can be inhibited by the same drug. So this is a landscape that's rapidly shifting, and there's a lot yet to be learned and seen. Now, when we look at the selectivity for the SGLT2 and the SGLT1 receptors, we see that DAPA, IMPA, and CANA have high selectivity for SGLT2 compared to SGLT1 because this is the ratio that we see. But there's much more selectivity for one. You see this is a smaller ratio for CANA than for these other two drugs. You can see that this dual inhibitor has a very low ratio, which means that it has comparable selectivity for both SGLT2 and SGLT1. Okay? And so this is one of the reasons why canagliflozin will be seen to have effects on rates of absorption of glucose from the gut, because it also has this spillover specificity for SGLT1 transporters, and that's here. There's a small number of these in the kidney, but they're much more important in the gut, okay? SGLT2, we've already emphasized that this is really for glucose primarily and almost exclusively expressed in the kidney. So in the kidney, you have low affinity but high capacity for glucose reabsorption by SGLT2, high affinity but very low capacity with SGLT1 in the kidney. This is going to be reversed in the gut. Okay. Now, I'm going to take you through some of the clinical trials evidence that essentially gives you a sense of what the landscape is in the abilities of these agents to do the things that we're excited about. A1C studies in monotherapy, okay? Here we see canagliflozin, empagliflozin, and ipragliflozin, which has not yet been approved. And what you see is that basically in this period of time with comparable baseline A1Cs, they all show evidence of being able, compared to placebo, to lower A1Cs in relatively short periods of time. These drugs do not require long periods for their onset of action. You can see the benefits of their effects in a matter, clearly, of hours to days, quite frankly. If you look at DAPA across 24-week studies, here we're looking at not monotherapy, but add-on therapy. Add-on to metformin, add-on to sulfonylureas, add-on to PIO, even add-on to insulin. This is one of the features of these agents in the SGLT2 class that really makes them so different. They're compatible with anything that we now use for the treatment of type 2 diabetes. Why? Because they don't depend on what the status of the beta cell is. It can be early in diabetes, it could be in the intermediate stages of diabetes, it could be late in diabetes when the beta cells are essentially no longer functional and people are reliant on insulin. this mechanism is still capable of reducing glycemic burdens because it is insulin independent. And it can occur for a while. This is the increased urinary glucose excretion that you see over time. And these are one-year data, but you can see actually this has been demonstrated for much longer periods of time. That is, the constant ingestion of this agent, dapagliflozin, can show evidence of being able, as long as the kidneys are working, to excrete glucose. My friend Richard Aguilar in California is like Quimeni. He uses these bad words. He says, the more the kidney sees, the more the kidney pees. See, I'm not allowed to say things like that. So I say that the more the kidney ruminates, the more the kidney urinates. So I'm still trying to teach that man something. So, okay, fasting plasma glucose. And I only want to make the point that if we're looking at A1C reductions, the question is always, what's the balance? Is it postprandial? Is it fasting? With these agents, both are effective, okay? You can see that with CANA and with IMPA, that in a dose-dependent fashion, in these 12-week studies, you can see reductions in fasting glycemia that occur across the board. Secondary benefits. This is with empagliflozin, okay? This is compared to sitagliptin on a background of metformin, weight neutral. That's a good thing when you're improving A1C, but it's a better thing for many of our patients when you can see a reduction in body weight over time on a background of metformin. Same effects can be seen across the board. Very exciting as an affirmation of the insulin independence that we talked about. What happens when you give these agents, and I'm using DAPA here, I could use any of them, as add-on therapy to insulin over time in type 2 diabetes? What do you see here? What you see is that in the absence of DAPA, you see that there is, in fact, over time, an increase in the mean daily insulin dose. You need to titrate the insulin up in order to get a comparable effect on the A1C. When you add DAPA, what I didn't show you is that the A1Cs actually get better on comparable or lower doses of insulin. In other words, there's an insulin-sparing effect. You'd expect that because you're getting a reduction in the ambient glucose burden through glucosuria, and now you don't need as much insulin for comparable effects on A1C. And then finally, what we have here is this unique ability that is shown by the dual effects of these agents on SGLT2 and SGLT1 transporters. If you look at these data, and they were generated with canagliflozin, what you see is a mechanism of the rate of appearance of glucose after oral administration of glucose. Okay? Or you can see the same thing with a mixed meal. And you can look at urinary glucose excretion. Okay? And what you see is that this is glucose absorption. This is urinary glucose excretion. And what you see is that there is, in fact, a reduction in glucose absorption in the gut under the influence of this SGLT2 inhibitor, which now has crossover specificity for the SGLT1 receptor. And when you look at the rate of appearance of absorbed glucose from the gut, like an OGTT here, what you see is that there is a reduction of the rate of glucose in the absorption profile. And this basically shows the same thing, that canagliflozin can delay the appearance of oral glucose. And I simply want to make the point that it is because of that combined specificity. And thus you see over time, compared to agents like glimepiride, you see that agents like canagliflozin show this impressive and sustainable reduction in A1C over time. Quick in onset, persistent in effect, with impressive secondary benefits. Those are the primary benefits, the A1C reduction and fasting and postprandial. What about the osmotic diuresis? Share a quick tidbit with you. When birds want to get rid of impurities in their bloodstream, if they want to get rid of excess agents in their bloodstream, like if there was hyperglycemia, birds can actually do it through solid waste. Because except for two birds, ostriches and rheas, birds don't urinate. They don't pee, okay? They have a defined special organ system, an organ called a cloaca, that will allow them to generate solid waste material to get rid of materials in their bloodstream, impurities. Well, we can't do that. If we get rid of stuff, impurities, and solutes in our blood like glucose, we got to take water with it. That's what we do. And that's an osmotic diuresis, and that's why we get this blood pressure effect. This reduction in systolic and reduction in diastolic blood pressure that you can see with canagliflozin, empagliflozin, dapagliflozin, ipragliflozin, all of the gliflozins can do it, okay? And you can see this demonstrated with DAPA, just in fair balance. And the vital signs show that these reductions in blood pressure occur without a comparable increase in pulse rate, okay? Now, don't know exactly what that implies yet, but it shows that you aren't getting a lot of volume contraction with the necessity for compensatory tachycardia. And then the lipid patterns that change, the only thing I would say for you is this, that LDL is not a part of the diabetic dyslipidemic profile, okay? So while there is a modest increase in LDL with these gliflozins, these SGLT2 inhibitors, there is no disruption of the diabetic dyslipidemic profile. You don't see exacerbations of triglycerides. You don't see reductions in HDL. In fact, if anything, you see an increase. So you don't see deleterious movement in the lipid profile. In fact, what you see when you look at the SGLT2 inhibitors, you see actually benefit across the spectrum of the cardiovascular risk factors. Glycemic efficacy, fast onset of action, no hypos, you see weight loss, you see blood pressure reduction, and you see equivocal effects on these lipids. And then the adverse event profile, the only thing that is really a consistent outlier are these mycotic infections. More in women than in men, more in people who have a prior history of mycotic infections, more in men who are uncircumcised. But recurrence rates are and can be low. And when you compare IMPA with sitagliptin, quite frankly, what you see here is that there is a comparable safety profile that actually looks pretty robust. So the emergence of these novel therapies are really beginning to show the following, that when you think about ideal drugs for type 2 diabetes, how do these new agents measure up? Is the A1C reduction robust? Well, yes. It's superior to sitagliptin and to some of the sulfonylureas. There is durability. There is the colors have gotten all screwed up with this transposition to this background stuff here. That's why I don't like that. There is improvement in beta cell function, but that has yet to be proven more. Low risk of hypoglycemia. Can't nobody read this white lettering on all of this pale stuff. Weight loss has been observed. It's well tolerated, except for the genital urinary tract infections, and it's simple to remember. So this is the end. These are drugs for all seasons in type 2 diabetes. We're now meeting unmet needs. We don't know yet whether they modify the progression of the disease. Still a work in progress. But they're independent of the beta cell status, indifferent to the stage of disease. They avoid the baggage that we're concerned about. Low risk of hypos with good efficacy, neutral or beneficial in their impact on cardiovascular risk factors. In fact, some of the meta-analyses of the cardiovascular benefits look pretty darn promising. And they're easily and reliably used by patients and with sustainable benefits. And that's why the ADA has elevated them to second-line status along with all of the other therapies on top of metformin as a choice in the treatment of type 2 diabetes. And so this is a summary. I've already summarized this about 14 times, so I'm not going to summarize this again, Mr. Chairman. I'm just going to sit down. Thank you all very much.
Do we have to be concerned about sodium since we're eliminating glucose via the kidney? Of course, you said that it followed the sodium. Do we have to now add a little more sodium to the diet, or do we, how do we deal with that?
Nope, not exactly, because the kidney maintains that balance. The purpose of the kidney is to maintain proper intravascular volume, and part of that is to balance sodium, potassium, and the other electrolytes. So the kidney does what it does. So even though there's this gradient created, it still has adequate balance, that these people do not become hypo, they do not become hyper or hypoglycemic. I've not seen any data showing that.
And in terms of sodium reabsorption, the mechanism for sodium reabsorption is a little further down the tubule. And so by the time the sodium glucose transporters have done their thing with glucose, the recapture of sodium where needed is intact later on down the pipe.
Thank you. Yes?
Thank you. Great presentation.
Can I say one?
Yes, sir.
The only caution is when you have people on diuretics, because
Yes.
now you get a volume and sodium problem.
Yes.
We're so excited about these new medications. However, with the high deductible plans that the patients are now facing, the medications are costing thousands of dollars. What are your recommendations? We're just across the river from Canada. I'm not sure what you think about Canadian medications and what solutions we might take back to our patients.
You notice they're kicking the policy question to me,
we'll,
right?
We'll leave that to Dr. Jones.
Well, to be quite honest with you, it is truly a national policy question. There are pressures that are being put on plans to make sure that even with high deductible plans, that they don't preclude patients from being able to get effective medications that would tie their clinicians' hands. So the key way to make sure that you do have access to appropriate medications at appropriate costs is all politics acts locally. Many of you in this room may take care of elected officials. Interface with them, let them know the challenges that you're experiencing with caring for your patients. Visit them in their district offices and have them to make sure that they lay a foundation for that. Plans will do what plans will think they can get away with. And if regulators step in and preclude plans from being able to do that, it will help us to make sure we can get for our patients what they need. There's no direct answer. I hope that helps some. I'll share this with you, and this is a compliment to something else that came up today. About 7 years ago, I funded at my institute at the University of Mississippi a study by a renal physiologist, a renal physician, a nephrologist, who's now at the NIH. He identified in Mississippi that we had an extremely high number of individuals who were going on to end-stage renal disease with no prior history of uncontrolled hypertension and uncontrolled diabetes. It's amazing. The medications that you're seeing now will go a long way in helping to stop that march if you apply the things that you got out of today's session along with the other information we get from this meeting. It'll help to make our communities healthier, and those are the people we care for. Gentlemen on the panel, thank you very much. Ladies and gentlemen in the audience, thank you very much.
Thank you, sir.